I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. I am a very dear friend of mine and one of the true leaders in the field of surgery in the US and abroad, Dr. Warren Hammert from the University of Rochester. Dr. Hammert is professor of orthopedic surgery and plastic surgery and chief of the division of hand surgery within the Department of Orthopedic Surgery at the University of Rochester. By way of background, Dr. Hammert completed his bachelor's at Oklahoma State University, and then subsequently actually got his DDS degree at the University of Oklahoma College of Dentistry, followed by his MD from the Medical College of Pennsylvania. He then completed oral maxillofacial surgery and general surgery at Allegheny General Hospital, and then subsequent to that, completed plastic surgery at the Cleveland Clinic, and then hand surgery at Buffalo. Dr. Hammert, as I mentioned, is chief of the Division of Hand Surgery within the Department of Orthopedics at the University of Rochester. He is incredibly involved in the Hand Society and is truly one of the leaders. He is currently one of the council members at large, which is a 3-year term on ASSH Council. He was formerly a senior director on the board of the American Association for Hand Surgery, and he's a past program chair of the American Society for Surgery of the Hand as well. Dr. Hammert has received multiple research grants covering a wide variety of topics, everything from artificial intelligence to machine learning to studying flexor tendon scarring and healing, distal radius fractures in the elderly, and many other topics. So clearly very involved in research as well. I think one of his biggest contributions to education really has been through Hand-E. He's the editor of Hand-E, which is ASSH's electronic educational platform. And I think for those who haven't had a chance to visit Hand-E, I think it's really an incredible repository of high-level talks on pretty much all topics hand-related. He's an editor of 9 textbooks. He's a reviewer for 7 journals. I won't list them all here, but I think you really get the idea. He is either chair or has been a chair or member of 33 ASSH committees. So when I talk about involvement, clearly Dr. Hammert is extremely involved in our national society, and he also has been a member of 6 AHS committees. Sorry for the misspelling there. On a personal level, it's been really fun getting to know Warren over the last few years, and we're both in the Manus National Hand Club, and we've had a few speakers from Manus over the last few weeks. Dr. Jeff Yao, as you can see here. We've had Dr. Sanj Kakar as well as Dan Zlatolau as well. So it's been a really big honor for me to be part of this club. Warren, for being with us. It's really an honor to have you, and we're really looking forward to hearing your talk, which we personally find very interesting considering what we do.
Well, thank you so much for the kind introduction. I've seen many of the other presentations, and I'm truly honored to be asked to participate in this because you have a tremendous number of outstanding presenters that have presented in this series, and so I really appreciate this. So I'm going to see if I can make my okay. Hopefully everybody can see me and can hear me okay.
It looks perfect, and we can hear you as well.
Perfect. So what I've decided to talk about is vascular disorders in the upper extremity, and this is something that I've actually had an enjoyment in taking care of these patients for a long time. It's a little bit unusual and not kind of a mainstream thing that you think about with hand surgery, but I've enjoyed the opportunity to treat these patients, and hopefully I can share some of my thoughts on how I handle the problems. So we're going to really kind of focus on chronic ischemia and vasospastic, or what I call vaso-occlusive disorders, and I'll go through how I think about these problems. So when people think of New York, most people think of New York City, and Rochester is part of upstate New York, but sometimes kind of forgotten. So New York City is down here. We're actually closer to Toronto across Lake Ontario, so it's about a 5.5-hour, 6-hour drive to New York City. So although I'm from the state, it's far from what people think of when they think of New York City. This is the High Falls River, which is a river kind of near our downtown. This is kind of Rochester in the evening, so much less crowded than New York City. And this is one of the Finger Lakes, Lake Canandaigua, which is just south of us, about 40 minutes. Beautiful area. So I said, much different than New York City. And so I'm enjoying my time here in the summer because I can't travel, and this is the best time of the year in Rochester. So again, I appreciate the introduction, Babak. So from a standpoint of disclosures, nothing to disclose related to this presentation. As he said, I am the editor of Handy, and that is a site that's available to anybody that wants to go and view it. So anybody that hasn't seen it, if you go to ASSH.org, you can sign up and have access to all of our educational material. So when I think about this topic and talk to people about it, they say, why do you want to take care of these patients? You look at fingers like this that come in the clinic, they're necrotic, patients often have severe pain. And I kind of think about it and I say the answer is because I think you can really help these patients. They've often bounced around quite a bit. They have trouble finding someone that will take care of them. Most of the time, they're not the healthiest patients, but I think you can really help them out quite a bit if you're willing to look at their problems and figure out a solution for them. So when you think about upper extremity vascular disorders, these are certainly less common than those that involve the brain, the heart, or the lower extremity, but they can cause significant problems with quality of life, diminished function, and in some situations often end up in morbidity and mortality. I try to break these down into two broad categories when you think about chronic ischemia. The first is vasospastic disease. And this has kind of two subcategories. That's primary vasospastic disease, which is referred to as Raynaud's disease. That means there's no underlying cause that's identifiable. Or secondary vasospastic disease, which is much more common. And this is referred to as Raynaud's phenomenon. So a bit of nomenclature, but this will occasionally come up on tests, certifying exams, and things, the difference between those two. Collagen vascular disease, such as scleroderma, is one of the more common causes of Raynaud's phenomenon, but can occur to any other condition. And then occlusive disease can cause secondary vasospasm due to showering of emboli distally. The other broad category is occlusive disease, and there's three components that I think of when I think of occlusive disease: embolism, thrombosis, or aneurysm. The key question when you're treating these patients is what's the collateral circulation like and what's the sympathetic tone like? And that's going to help with your decision for treatment almost regardless of which condition you're treating for chronic vascular disorder. If you look at vasospasm or vasospasm that's enough to become symptomatic, about 10 to 15% of the people report sensitivity in their fingertips and their toes to cold. And 20% of the population in northern climates often will report blanching and digital numbness. And that certainly where I live in upstate New York can be fairly symptomatic in the summer. And I guess if you think about Mark Twain's quote, the coldest winter I ever spent was the summer in San Francisco, that may be the same for what you experience there at times also, even though you may not have the frost that we have. Two components to this, the macrocirculation and the microcirculation. When you're looking at these patients and starting to evaluate them, what you want to determine is the competency of the vascular system. And by this, I mean the ability to regulate the blood flow to fulfill the metabolic requirements and maintain cellular viability. It's dependent upon the anatomy of the vascular system, the collateral circulation, the vasomotor tone, and the metabolic demands of the tissues. So when this system is not competent or is incompetent, this can lead to pain, cold intolerance, numbness, and eventually tissue loss. The microcirculation is the other component. And this has two portions as well. The total blood flow is made up of the thermoregulatory blood flow, and this is responsible for about 80 to 90% of the circulation. And this can be shunted prior to the nutritional channels to help with temperature control or maintain blood pressure. And the final 10 to 20% is the nutritional blood flow, and this is what provides the cellular metabolic needs for the tissues. And so we're all familiar with the radial artery, the ulnar artery, the superficial and deep palmar arches, and the digital vessels. But what's often forgotten about or sometimes overlooked are these connections out in the fingertips between the arteries and the veins. And this is where the nutritional capillaries live. And so this is a picture from an older version of Green's operative hand surgery, but you can see the nutritional capillaries out at the tip, the AV anastomosis before that. And this is the part that's really responsible for the cold sensitivity in patients that have Raynaud's, or the ulcerations and wound healing problems in patients that are more advanced. So when you're examining these patients, similar to everything else, you're going to look at capillary refill. Things specific to this, you want to look for presence or absence of any ulcerations or tissue loss. You want to palpate the pulses, and then you can examine the filling of both the radial arteries or the digital arteries with an Allen's test. I think a handheld Doppler is essential to be able to evaluate these patients. And so there's a variety of them. I'm not sure there's one that's necessarily preferred or better than the other. This is the one that we have in our clinic, and it works very well with the little Doppler gel. And so after you've examined the patient, you start thinking about the diagnostic test. And the goal of these is to determine the anatomy of the vasculature and its capability to respond to stress. And stress is often thought of as cold or changes in temperature, because that will induce vasospasm. But warming can be a positive stress, and then it can cause peripheral vasodilation and actually improve the circulation. So you want to know how the vasculature changes when it's either cooled down or when it's warmed up. And you want to look at the total blood flow in both these non-stressed and stressed conditions. There's a bunch of tests that are ordered or that can be ordered that provide useful information, but the two that I highlight and I find are available in most labs and usually are helpful to make the decisions are the segmental arterial pressures, DBIs or digital brachial indices, or the digital plasmography, PVRs, or pulse volume recordings. And these are the two that can be obtained in most labs and usually give you good information as far as the flow that's to the hand or the digits. When you think about the segmental arterial pressures or digital brachial indices, these are essentially just ratios of blood pressures. So you're using a Doppler unit to obtain the systolic blood pressure. You're measuring the brachial artery pressure and then the digital artery pressure. And you come up with a ratio as to what is normal or what is abnormal and concerning for lack of flow. And so a normal digital brachial index should be about 90%. So the digital pressure should be 90% of the brachial pressure, and that gives you a number of 0.9. When it's less than 70% or less than 0.7 for this number, that's indicative of inadequate arterial inflow and supports the need for intervention because tissue loss is imminent once the level falls below that. So when you get something back from the lab, it often will look like this. They'll have the interpretation, and then they'll describe the waveforms being dampened, being normal appearance. And so usually the brachial, radial, and ulnar arteries are okay, and you don't see changes till you get out further distally. And so like most labs, probably our lab likes to send the report, and sometimes you have to battle with them a little bit to actually get the information that you want. And just as you want to see an MRI rather than just reading a report, or see the electrodiagnostic numbers rather than just reading the interpretation, I always like to look at the results of these tests. And so this is what you get back as far as the pressures. They give you the brachial pressure, the radial, the ulnar pressure, and then they'll give you waveforms that go with it. And as you follow it out into the fingers, you can see here, as I'm looking at the screen, it's on my left, you can see the red waveforms are pretty good, but when you go to the small finger, it's a little bit more flattened. If you look at the left side in green in this, you can see flattening of the third digit, and you can see the numbers, the right fifth digit, 61, the third digit, 49. And when you go over to this area here, you can see significant flattening of almost all of the waveforms over there. And so that's a patient that's got a much greater concern for lack of circulation. For occlusive disease, the diagnostic test is an arteriogram, and I think that's really the gold standard. MR arteriograms or MR angiograms are better, and they do have the ability to evaluate venous flow, but they're not nearly as good as arteriograms for defining the distal anatomy most of the time. CT angiograms, I think, are good for AV malformations and higher flow lesions, and they're better proximal than distal. I don't find those very helpful at institutions that I've worked at or when I've seen outside CT arteriograms to evaluate the circulation distally in the hand or fingers. So this is an example of an MRA, and it can be helpful at times. This is a mass, and so it was ordered for a mass, but turned out to be an aneurysm of the ulnar artery. And so you can see on the left the early and on the late the right venous phase. And that's one advantage that you do get from the MRAs, but I still like the traditional arteriogram for evaluation of vascular problems. So most patients that have chronic vasospasm can be managed medically. A very small percentage of these actually end up needing surgery. And so the base medical treatment are calcium channel blockers, nifedipine, or diltiazem both work well. Tricyclic antidepressants such as amitriptyline, the SSRIs, the alpha-2 agonist, and the phosphodiesterase inhibitors such as Viagra all cause vasodilation, and those all are pretty good medications and first-line medications. I don't like to prescribe these on a long-term basis. Occasionally, I will prescribe them initially or in conjunction with the rheumatologist or the referring physician. Will start them and then pass that back to them to manage that if they're effective. The newer medicine, or the medicine not necessarily newer, but I've become involved with recently working with pulmonologists, is prostacyclin, or PGI2. And this is Remodulin is the IV form, treprostinil is the oral form. This inhibits platelets and it causes very prompt vasodilation. And so the pulmonologists use this to treat pulmonary hypertension. And that's how I kind of became involved with working with them. They had some patients that had scleroderma with severe pulmonary hypertension and ulcerations, and they noticed that there was some improvement in their ulcerations when they were treated with this medication. So they get admitted to the hospital and they treat in there, helps with their pain, it helps improve their circulation, and with time it can help their ulcerations heal. The challenge is it's a very expensive medication and hard to get it covered by Medicare and even some of the private insurances. Then similar to Dupuytren's disease, there's the non-surgical alternative of Botox, or onabotulinum toxin type A. And so the concept here is you inject 100 units in the perivascular tissues, and this can cause vasodilation. The mechanism of action is not completely understood, but it does seem to cause vasodilation, at least in a group of patients. There's several level 4 studies that demonstrate or report pain relief and healing of ulcerations. Mike Neumeister, Alan Van Beek are some of the authors that have some of the earlier papers with this. More recent papers, this is from 6 years ago now, but 2014 in the European Journal of Hand Surgery, a prospective study looking at botulinum toxin injection for Raynaud syndrome with scleroderma. They looked at 20 patients, 100 units of Botox. It's interesting, I'm not sure anybody knows why 100 units of Botox is preferable or better. The best answer that I can get from people that I talk to is the vials come in 100 units, and so we use 1 vial per hand, and that's how we get 100 units. So you divide the 100 units by 5 digits, and it's essentially 20 units per digit. But I don't think that number is based on any scientific data. It's just based on the way that the vial comes. So they followed them 8 to 12 weeks. 16 out of the 20 had improvement in symptoms, less cold intolerance, less pain, and better DASH scores. 18 had improvement in pinch strength. The best paper, I think, on this topic was out of Johns Hopkins, and Scott Lifshay was the senior author. It was a double-blind randomized trial comparing Botox and saline. And in their patients, they had 40 patients, 25 that had limited scleroderma, 15 that had diffuse. And they actually showed that the Botox group did worse than the group with saline. And so in their situation, or in their study, it wasn't proven to be as beneficial as it seemed to be in the other studies. And they thought it was mainly due to their cohort having long-standing disease. Many patients with diffuse scleroderma ended up with the Botox, and it doesn't seem to be as effective later in disease process or with more advanced disease. So when you get into the surgical treatment for these, when the patients are not getting better with the non-operative treatment, surgery is actually a very fun operation, and I think it can really help these patients. So sympathectomies can be done in the digits as depicted here on the right. This was initially described by Shaw Wilgus and Adrian Flatt, or the picture on the left where the palmar arch and the radial and ulnar arteries is popularized by Andy Komen. And so when I'm treating these, initially I use the palmar arch, the radial, and the ulnar arteries, and then depending on whether it's more radial or ulnar-sided, sometimes I'll do the radial artery in the snuff box as well. And then I save the fingers for secondary or repeat surgery, because trying to do a repeat sympathectomy after you've done it once ends up with a lot of arteriotomies and often not a very enjoyable day in the operating room. So we'll go through some different cases. This is a young lady. You can see some necrosis at the tip of the index finger here. We're going to treat her with the sympathectomies as I described: radial artery, ulnar artery, palmar arch. And here you can see after we've done the sympathectomy, dilated the vessels. You can see vasculature or blood flowing through that there. There you can see her about 6 months with healing of the incisions, healing of the ulceration on the index finger. So I think the sympathectomies work really well in patients that have vasospasm, and it maybe is even a better operation early in the disease process. One thing that's very important is I think you have to evaluate these patients for occlusive disease as well, because although their problem is primarily vasospasm, I think now there's evidence to suggest that many of these patients also have thrombosis, and particularly the ulnar artery. And so I always get arteriograms on these patients before I operate on them, just to make sure if there's something that's amenable to a bypass, I will be able to do that. If you look at this paper from Jim Chang's group at Stanford, they looked at 110 upper extremity arteriograms over about a 21-year period, and they classified this into 4 types and 3 subtypes. But what was notable is 57%, or just under 2/3, were noted to have a non-patent ulnar artery at the wrist, and this is quantified as type 2. And of those, 3/4 had a non-patent superficial palmar arch. So it tells you that we're probably waiting later than ideal to try to treat these patients. And so here is an example of their systems, or their classification of the system. Type 0 is normal. 1 is impairment of the palmar arch. It can be the deep or the superficial palmar arch, or both. Type 2, which is the most common type, was impairment of the ulnar artery. You can also see impairment of the radial artery, or as depicted here in 4, impairment of both the radial and ulnar arteries. And so the more that's occluded, obviously, is the harder time you're going to have trying to reconstruct these patients and improving their flow, decreasing their pain. So this is an example of patient combined vasospasm and thrombosis, very young patient, 22 years old, history of Raynaud's phenomenon, had a sympathectomy in her teens at another institution, recurrent vasospasms, finger ulcerations with necrosis of the index and middle finger tips. She was admitted to the hospital, treated with IV Remodulin. In our workup, we get the arteriogram. I use these with before vasodilation, then I have them inject vasodilators just to see if they change. And this is a pretty typical appearance of the arteriogram. What I think you often find with this is there's a pretty predictable dorsal branch, and this is about the area where the occlusion occurs. And so this distance here seems to be pretty consistent in the patients I've treated. It's about 7 to 9 centimeters as far as the length of the graft that you're going to need. So if you're going to graft these patients, rather than just doing a sympathectomy, which I think makes sense if you're comfortable with the microsurgery part, you have to decide what type of graft you want to use. Vein grafts, there's an abundance of material, but they can be challenging. You've got to reverse them or remove the valves. There's often a size mismatch between the vein and the artery, and then the vein has thinner walls typically than the artery. And so it makes it a little bit more challenging to do that anastomosis, but certainly can be done and was done for a long time. Over the last 10 plus years, arterial grafts have become used more commonly in the upper extremity. They do have some limitations. There's a limited graft length, and you need to have an expendable artery, but it do have advantages because there's no valves, so you don't have to reverse them. The diameter and the wall thickness is fairly similar to the ulnar artery if you choose the right donor arterial graft. And so that's kind of been my transition for the last decade or so to use arterial grafts for these. And so it's kind of based on the concept of cardiac surgery, higher long-term patency we know with internal mammary arteries for their bypasses, same thing with the radial artery. And so you can also find branching patterns that are similar. So if you need to do the anastomosis into a couple digital vessels into the superficial palmar arch off the ulnar artery, you can usually find a branching pattern and do end-to-end anastomosis rather than end-to-side anastomosis, which you often have to do with a vein graft. So as I said, based on the concept from the cardiac surgery literature, if you look at our evidence, there's more papers that are coming out, but we're still somewhat compromised as far as the number of peer-reviewed publications on this. So it's a systematic review done by the group at Baltimore with Jim Higgins from the Curtis Hand Center. Systematic review, 16 studies, 145 patients, 152 grafts. So 120 of these were for the ulnar artery, so that was dominantly the part that was reconstructed. Patency rate, 87% at 34 months. When you look at the breakdown on 19 arterial grafts, and all of those were patent at 18 months, compared to 133 vein grafts, which only 58% were patent at 37 months. So not a perfect study or a review because the number of arterial grafts is much less, the follow-up is much less. Nevertheless, the difference in patency rate from 100% to below 60% is quite remarkable. So when thinking about the specific graft, these are the ones that I think are reasonable to use for upper extremity: thoracodorsal, the deep inferior epigastric, the descending branch of the lateral femoral circumflex artery, and the subscapular artery. And all of these, I think, are expendable and can be used for this type of reconstruction. There tends to be a predictable length of about 10 to 15 centimeters in these grafts. The diameter is about 2 to 3 millimeters, which tends to match the ulnar artery or radial artery pretty well. As I said, the lateral femoral circumflex artery has multiple branches, so it makes it easier to do the end-to-end anastomosis. And I find the lateral femoral circumflex artery pretty straightforward to harvest most of the time. Plastic surgeons tend to be comfortable in this area because the anterior lateral thigh flap is harvested off this vessel, and orthopedic surgeons with approaches to the femur can find this pretty easily as well. So the groups of patients that are surgeons that are typically taking care of this, a little bit easier to find than the deep inferior epigastric or the thoracodorsal for orthopedic surgeons that may not have as much exposure to working in those anatomical areas. To find this, essentially a line between the anterior superior iliac crest and superior lateral aspect of the patella, knowing the vessel is going to run in the interval between the rectus femoris and vastus lateralis. So it's deep and the patients are a little bit sore after you harvest this graft, but it's pretty straightforward to harvest. So here you can see the patient depicted earlier. We've got a couple defects. We've got the primary one plus a digital vessel that we're going to repair with a couple grafts here. And here you can see the graft being harvested between the muscles. And here you can see the graft put together just before final closure to revascularize the hand. Here you can see the patient at 3 weeks. She's got some eschar around her incision as well as eschar at the tips of the fingers. But they are bleeding, which they had not done previously. Here you can see 3 months, the appearance of her wounds, and here you can see the fingers at 3 months with much better appearance at the tips. As I said, there tends to be a predictable graft length for this. Here you can see the length that's pretty predictable, and so that generally means that there's enough graft from any of the previously mentioned arterial grafts to do this type of reconstruction. If you look at this paper from Duke from 2017 in the European Journal of Hand Surgery, they compared patients that had sympathectomy alone with sympathectomy and bypass. And so again, an unequal number of patients, but at follow-up of 2.8 years, the group with sympathectomy and bypass had better resolution of ulcers and less pain. So another reason to consider the sympathectomy and bypass in a patient that has occlusion of the ulnar or radial artery. It's a paper from Wendell Merritt published in Hand in 2018, 46 patients, 58 sympathectomies over a period of 35 years. So essentially his career as a hand surgeon, mean follow-up of 4 years, almost 60% had connective tissue disease. Vein graft reconstruction in his series was a little bit higher than most of the others, so over 3/4 of those were patent long-term. And what's interesting is even when the vein grafts are not patent, patients still seem to have less in the way of symptoms. So I think there's unanswered questions about this condition, scleroderma, sympathectomy, bypasses. What we really don't know is when is the optimal time to do this. Should we do these procedures earlier, maybe before they develop symptoms, before they have a lot of pain, with the idea of decompressing the ulnar artery and doing the sympathectomy to improve pain early and hopefully maintain the patency of that? Should we wait until they have pain? Or should we do what's often done, wait till there's ulcerations, necrosis, all the medical treatment has failed, and then treat them? And in some situations, this ends up being too late. So this is an area where I think we can get more information over the years, over the upcoming years, hopefully, and end up with better treatment for this. I think the key is establishing treatment teams and referral patterns. A lot of times the rheumatologist and the other physicians that may treat these patients don't really understand what can be done to improve the circulation, or they're not sure it's effective. And so there tends to be a delay in referring patients. And so that ends up with a delay in treatment, which ultimately leads to not as good outcomes. So let's shift gears a little bit and now talk really about more occlusive disease and not related to collagen vascular disease. This is a 38-year-old manual labor, pain and numbness, 6 months duration, increasing in severity. Hopefully you can see the pictures, but some changes over the middle and ring fingers mostly. You get an arteriogram and it often will look like one of these two, the one where the ulnar artery is completely occluded, or the one on the right where you have that corkscrew appearance of the ulnar artery, which is an earlier arteriogram. But this is an example of Hypothenal Hammert syndrome, or ulnar artery thrombosis. And what happens with this, the ulnar artery and ulnar nerve are more superficial. And so there's repetitive trauma where the hand is used as a hammer. And with time, you either get disruption of the internal elastic lamina or lining, or you get periadventitional thickening. And this can result in either an aneurysm, so there's dilation, and there's thrombus within that can shower microemboli distally, or you can just get thrombus that actually occludes the entire artery, and you can end up with no flow through that. But these patients often have some degree of vasospasm as well, because those area of thrombosis can shower microemboli distally, and that can cause the vasospasm to occur. So the treatment of this has historically been resection of thrombosis using a reverse saphenous vein graft in the event that there is critical ischemia. In patients that have good flow through the radial artery, you could do a Lorite sympathectomy, which is essentially just a ligation and excision. The reason you want to take it out again is to try to minimize the microemboli from showering distally and the problems that can result with that. So it's an example of a patient with ulnar artery thrombosis. Here you can see a larger segment than usually. Usually it's about 2 to 4 centimeters where this segment is thrombosed. This was a little bit larger to get back to kind of a normal lumen for the ulnar artery proximally and distally. And here you can see after the graft is inserted, the microvascular anastomosis is done. We've got good perfusion of the hand and good filling of the graft. If you look at the literature on Hypothenal Hammert syndrome, long-term results with vascular reconstructions, this is from the Mayo Clinic about 5 years ago now. What they noted was that at 118 months, 14 out of their 18 vein grafts had occluded, and the groups that occluded tend to not do as well as the ones that were patent from a standpoint of cold tolerance, but they did have similar dash scores and similar grip strength. And so for some reason, even when these thrombose late, patients tend to have less symptoms than you would expect. This is a paper from the European Journal of Hand Surgery where they used an arterial graft, Hypothenal Hammert syndrome, follow-up after ulnar artery reconstruction with the lateral femoral circumflex artery. They looked at 11 patients that had this arterial reconstruction. 9 out of 11 were patent at 63 months. So not all of them, but still a fair number. 9 out of 11 had improvement in symptoms. So in their group, patients that had patent grafts ended up doing much better. They looked at a historical cohort of 32 venous grafts, 85 months. So again, longer follow-up, but only 9 of the 32 venous grafts stayed patent. So if you kind of look at all the literature that's out there, it would give you the sense that arterial grafts probably have a better patency rate than venous grafts for upper extremity reconstruction. So you can have complete thrombosis. You can also have an aneurysm. From a test-taking standpoint or nomenclature standpoint, you can differentiate between a true or a false aneurysm. The false aneurysm is referred to as a pseudoaneurysm. And this involves a portion, but not all layers of the vessel wall. Typically results from a sharp or penetrating injury. So you'll see this after kind of a knife injury, a glass injury, a puncture where the artery is partially cut and they'll get this small focal area of dilation. As opposed to the true aneurysm, which contains all layers of the vessel wall and results from typically blunt damage, as you could see with Hypothenal Hammert syndrome or ulnar artery occlusion from that. the treatment is really going to be the same for either one of these. You're not going to be able to do anything different from the pseudoaneurysm to the true aneurysm. So here's the MRA that I showed earlier, the ulnar artery aneurysm. Most of the time when I've treated these, there's enough redundancy in the vessel that you have here so you can resect these and repair them primarily. Uncommon for aneurysms in my hands to need a graft just because there hasn't been that much of a defect. And so here you can see the example brought together, the primary anastomosis right at the branching site, and then you can see the blood flowing through after we've removed the clamps. So the next kind of broad category we'll talk about is end-stage ischemia. This is essentially calcific peripheral vascular disease, often associated with renal insufficiency. Many of these patients have had lower extremity amputations, and they present with kind of necrosis of multiple digits or multiple portions of digits. And you evaluate them and you get an arteriogram that looks something like this. And so you've got some flow in the forearm, really minimal to no flow in the hand. And so that's kind of a problem because there's nothing distal to bypass to. These patients often have ischemic pain. You can't amputate the necrotic part and expect it to heal, or you'll end up continuing to march forward until you go from a digital amputation to a transradial amputation to a below elbow amputation eventually to get enough flow for the wounds to heal. And so salvage procedure for this, the concept is, or the procedure I'll talk about is reversal flow or arterialization of the venous system. And so the concept of this is essentially to take a vein and use this to deliver oxygenated blood to improve the perfusion and allow the amputation sites to heal. This can be done with the cephalic or the basilic veins. You need to remove the valves, and then you're going to do an anastomosis of this vein once you remove the valves to either the radial or ulnar artery, or more proximally to the brachial artery. Early when I was doing this, I would go to the radial artery because it's a smaller dissection and tends to be pretty straightforward, but I found that the flow through the radial artery can be somewhat unpredictable. And at the brachial artery, there's almost always good flow. And so now that I almost always go to the level of the brachial artery because I think it's more predictable and it's going to give you better circulation. So the indications for this procedure, essentially end-stage ischemia without other means to improve the circulation. These patients will have ischemic pain, ulcerations, and necrosis are almost always present. And so they'll end up looking something like this with the fingers where they've got variable amounts of tissue loss on multiple different digits. It's a broad exposure. If you can take the veins out from about the mid-metacarpal or metacarpal neck level, there's generally enough pressure that you can perfuse distally and it'll blow through the little remaining valves in the fingers. So you need a valvulotome to do this. There's usually one in the vascular surgery set. This is a disposable valvulotome. I like the reverse cutting valvulotome, so you advance this and then you pull it as opposed to trying to push forward in these veins that tend to become fairly friable. This is one that I actually like better. It's called a leather Mills valvulotome. It's not disposable and it's a little bit harder to get, but we still have some at our institution that I've kind of saved. The vascular surgeons almost always use those disposable ones at this point, but we do have these around and I might be the only one that still uses them. And so this is kind of what it looks like. You're going to bring the valvulotome up. Going a little bit slow here, but you're going to move the valvulotome back and forth and you're going to release the valves. You go up, pull it back, turn it 90 degrees, pull it back, turn it another 90 degrees until you essentially have everything open and you can irrigate through that with saline or heparinized saline. So here's the exposure. The clips are on little side branches. The side branches are where I put the valvulotomes in to remove the valves. And then here, depicted on the right, we're going to do the end-side anastomosis into the brachial artery. And so here's what it's like. This is the cephalic vein. You can see the pulsation in it after the anastomosis is done proximally. And this goes all the way out into the hand. And just generally, as I said, will provide enough flow distally that it takes out the remaining valves. So another example of this type of procedure. Here you can see the side branches clipped. Again, end-side anastomosis into the brachial artery. Here you can see after the tourniquet's let down, perfusion through the cephalic vein. Here you can see healing of the amputation sites. If you look at the literature for this, there's really not much. I think this is more experience-based medicine than evidence-based medicine. There's case reports in small series. My personal experience with this is they've had substantial improvement in pain and healing of the amputation sites. A couple papers, we looked at 10 patients over 14 years. Not the most scientific paper, but it basically described our results. Patients typically had diabetes, end-stage renal disease, and lower extremity amputations, but the patient's ulcerations healed and the amputation sites healed. Another paper that we looked at with this, where we talked about the amputation of necrotic digits without addressing the etiology of the necrosis, often results in wound healings and more proximal amputations. So the goal with this procedure is to preserve as much tissue length as you can, and it also helps substantially with the ischemic pain. So kind of the final group of patients I'll talk about are those with Steele syndrome, often associated with AV fistula, but these patients often develop an ischemic pain during dialysis. And the vascular surgeons are always hesitant to go back and do anything with the fistula once it's working. But you really need to evaluate the fistula and to evaluate for stenosis distally, because what happens is essentially it just steals, and rather than flowing distally into the hand, all the flow is going proximally, and so it becomes an ischemic hand. The treatment really does involve something to either bypass the fistula, which is what the drill procedure is, distal revascularization and interval ligation, angioplasty if there's areas of stenosis, or other means to improve the circulation distally, because otherwise you can end up losing the hand without it. This is a procedure I don't have any experience with, but some of the vascular surgeons do open repair and venous inflow plication. Essentially, they're excising a segment from the venous portion of the fistula to reduce the size, reduce the amount of flow through that. But with these patients, because of the rapid return to the heart, you can end up with congestive heart failure, pseudoaneurysm, and other changes. And so I like the vascular surgeons to be involved with this type of procedure if it's warranted or indicated. So in conclusion, I'd say the patients that have vascular conditions certainly are challenging, much more so than some of the other things that that we treat in hand surgery, but not that much different than some of the complex wounds or other things that we end up reconstructing with microsurgery. Patients tend to be grateful for the help. They've often kind of been bounced around and they're undertreated. They can't find someone that'll treat their problems. But I think if you develop a team approach with a rheumatologist, a pulmonologist, or someone that's going to actually help with the medical management of things, you can really help improve the patient's quality of life. And as I said, I found this a challenging but very fun group of patients to treat. So I appreciate everybody's attention. That's kind of my thoughts and ideas on how I treat chronic vascular disorders in the upper extremity. So thank you very much again for the invitation, the opportunity to share this with everyone.
Warren, thank you so much for a fantastic talk, and I think this is really an important topic, and so I'm really glad to be able to have a recording of it in our library. And it was a really, really great review of essentially all types of vascular issues and the different modalities that are available to us. So thank you so much for that.
I appreciate it.
I'm gonna have a few questions to ask just based on some of our experience. And the first one is a question about anticoagulation. You touched on obviously the calcium channel blockers and so on, and we tend to be fairly liberal here with regards to our use of heparin, or even sometimes in really severe cases, sometimes even a home regimen for a month or so, really based on no real data, but just in low risk patients, we feel like sometimes it's helpful to more clot while they're dissolving the clots that they do have. Do you have any thoughts on what anticoagulation you use and when? That'd be great.
Yeah, so it's not very scientific based, kind of as you said, because there's not much evidence by it. So everybody gets aspirin, and I have them stay on that for at least 2 weeks, depending on how they're doing. And then depending on the condition, for someone, for example, with an aneurysm or hypothenal hammer syndrome that I'm doing, I just use aspirin and that alone. The patients that have scleroderma and other kind of more diffuse vascular problems often will end up anticoagulating with low molecular weight heparin. I let the medical doctors help coordinate that, but now then we can do it, just with a couple of injections, and you can fully anticoagulate them. So it's not like the days where you had to, start them on Coumadin and wait until they had an INR at an appropriate level. And then I don't have necessarily strong thoughts or opinions, but some of the patients will come in on Xarelto or some of the newer medications, and I just leave them on it. I don't stop those. I don't know how much they help, but I just let them stay because somebody else has put them on it.
Yeah, I think I totally agree with you. I think we also do aspirin, and we typically keep them on whatever their outpatient anticoagulation regimen is. And I think you're right, it's not really based on science, but I think it just makes intuitive sense. And so it's one of those things where, especially the more end stage type cases, you really don't have much to lose and pretty much only stuff to gain. Looks like we have Professor Bala from Chennai, India on the call. Professor, I see your webcam is on. Do you have a question or comment for Dr. Hammert?
Yeah, Warren, that's a very good lecture. I'd like to know from you, have you any experience on hyperbaric oxygen? Some of the early ischemia, we try to give hyperbaric oxygen and get out of them. Do you have experience on that, hyperbaric oxygen?
I do not have any experience with hyperbaric oxygen for this. The wound centers and stuff often will try to push patients that way. I haven't seen any data that's convincing. The only place where I've really personally had good experience with hyperbaric oxygen is osteoarterial necrosis of the mandible with reconstruction. But for ischemic ulcerations, often patients will ask about it, and I just have told them that I don't have the experience with it. I don't have anything in the literature that I'm sure or confident makes a difference, but I don't have a problem trying it. Have you used it for your patients?
Yeah, I have used it for a couple of my patients for early ischemia. If early ischemia, if they are not diabetic, definitely it does help for those patients for the distal ischemia of the fingers.
How many dives do you need to get them?
We get them into the chamber for 1 hour. 1 hour.
Okay.
And the
multiple
volume
times
is
or just one time?
No, they go for about 10 days. 10 days
Okay.
until they feel better, till they don't have pain in the fingertips. We continue to give them the hyperbaric oxygen.
Yeah, that's interesting. Yeah, I'm always interested in learning. I have not done that with any of my patients, and if that's something that helps, it would be interesting to have more knowledge about that.
Thank you, Doc.
Thank you for that question and comment. We also don't have HBO chambers here at our hospital, so I don't have any experience with that either. But it'd be interesting to look up to see who else is doing that and if there's any data on it. Thank you so much for that, Professor Bala.
It's also it's also FDA approved procedure for ischemic GERD.
Got it. Great. Thank you for that.
Thank you.
Thanks. The other question I had for you, Warren, is do you ever find yourself doing more multimodal type therapy in patients who are more end stage, just kind of throwing the kitchen sink at them with regards to arterializing the veins and maybe even trying to do a bypass or interposition graft or whatever, just in case, just try to give them the maximum, or even doing Botox at the same time, or a sympathectomy?
Yeah, so I think if there's something to bypass to, you're better bypassing into a distal target than the arterialization of the venous system. So the times I do that are when there's nothing that I can bypass to. So I'll often look at the radial artery in the snuff box. When I expose them, I will open up the radial artery in the snuff box, and if it's really soft and I can inject into it, I've done just in situ bypasses where I leave the vein, take the valves out, and just bypass distally. And I've done that a couple times, and that seems to have worked reasonably well. I haven't done the sympathectomies in conjunction with that. I think the sympathectomies work better when there's some component of vasospasm. And I do the sympathectomies in conjunction with bypasses for the patients with scleroderma, for example, but not for the end-stage ischemia, because those are more calcific arterial disease, and I just don't think those respond to the sympathectomies. They don't have pliable vessels like the vasospastic patients.
Yeah, that makes a lot of sense. And Chris Peterson talks about his experience with the in situ vein bypass after valvulotomies as well. And interestingly enough, there was a last year, it may have been the year before, on operations that I no longer perform. And Chris Peterson was talking about how he no longer does venous arterialization. I personally do it, and we do think that it does help in whom you don't really have a good target, or you're kind of out of options. But any thoughts on that? I didn't quite get a definitive kind of reason why he stopped doing it, but in our experience, it seems to help the patients who don't have any other options.
I guess that's interesting to hear. I guess my first thought would be maybe because he's only doing kids now, he's not taking care of adults with these problems in his new job. Because Chris Peterson is actually one of the people that really taught me this procedure many years ago,
Yeah.
and some of the other people. But so I learned a lot of the things that I did and took and developed or expanded on from Chris. So I was not aware that he was not doing, or that he wouldn't do it. But obviously, with him being a pediatric person for the most part, that may be part of it. But I don't know. I'll have to ask him. That's a good question.
Yeah. And then the other question I had was, we obviously, I think there's a big difference between when you do these arterializations of the venous system more proximal. I think you clearly have a lot of valves to go against. And the question for you was, if you do one more distally, even though you mentioned your preference to go more proximal, but let's say you do one of the distal forearm, for example, and the radial artery is pretty good, but you don't have a good distal target to bypass to, so we decide to arterialize the venous system that way. Do you feel that you need valvulotomies the more distal you go, or do you think that the arterial pressure is able to overcome some of the valves in light of the dilation that you get from the veins?
I guess my sense is, and the reason I started going more proximal is I just found the radial artery was inconsistent, and sometimes I do the arteriotomy, and it was, you'd put a embolectomy catheter up, but it was just thick, and you couldn't, it wasn't like you could pull a clot out and then you get the ideal spurting blood. I think once you get to somewhere in the metacarpal level, there's probably enough pressure that it blows out those valves distally. So if I was doing it in the radial artery, I would still take out the valves out to the mid part of the dorsal hand. And if I was confident that there was good inflow, I would stop. I wouldn't go further than that. But I'm just, and again, that's my level 5 experience. If you can show me that there's an easier way to do it, I'm always looking for an easier way. But I've done it that way just because it's been pretty predictable and worked as far as amputation site healing, ischemic pain getting better.
Yeah, no, I think it does make a lot of sense, and I don't have any evidence to the contrary per se, but it was just a question. We have more experience and more data, if you will, on the smaller veins, such as, for example, venous flaps. That's been shown in especially the Korean and Chinese and Japanese literature, that not reversing them is completely fine, because those tiny little veins, the distal wall of the forearm, tend to dilate quite a bit, and the valves are pretty much incompetent fairly quickly. I think the cephalic system is likely very different. And so we just don't know. So it kind of makes sense, especially if you're bypassing over a longer segment, to have to do the valvulotomies.
Yeah, when I think of the venous flow-through flaps, I think of shorter segments, 2, 3, 4 centimeters, as opposed to, going from the mid-forearm to the hand. So some of it may have to do with just the actual length of the venous graft as well.
Also, I think the veins by nature are much less muscular, so they dilate out quite a bit. I think the percentage increase in diameter in these little tiny vein grafts you use for the digits or venous flow-through flap, I think that probably explains why your valves, just even if they are there, just don't really matter anymore.
Yeah, they're not. They're the cross-sectional area they take up at that level is much smaller, and it becomes insignificant probably.
Exactly. Great. Well, Warren, thank you so much for a fantastic talk. It's great to see you, even though it's virtual. It's not as good as in person, but it was really an amazing talk. And I think in many ways, I was thinking about this when I was putting together your intro slides. I think, your practice and kind of the way you've built your division and the work you've done within the Hand Society and the Hand Association, I think, is in many ways kind of you're a role model for young surgeons, especially if you've been able to really bridge the orthopedic and plastic world, especially as a plastic surgeon. So just wanted to kind of mention that. I think for those young surgeons who are either here live or watching the video later, I think it's something to kind of strive for, if you will.
Yeah, well, thank you so much. Very kind of you. I've been fortunate that I've had a lot of opportunities and tried to make the most of every opportunity. And fortunately, that has often developed another opportunity that that came with it. So I appreciate your thoughts and your kind words. That's very very nice of you.
Great. Thanks again, and I look forward to seeing you virtually at the Hand Society meeting coming up, but hopefully in person soon as well.
Likewise, hopefully at some point we'll be able to gather in person again. And again, thank you for the honor of being able to present to your group and having this on your microsurgeon.org site. I'm very honored to be with all the other outstanding speakers that you've had. So thank you again.
Great. Thanks so much. Have a great night, Warren. Take care.
Okay, you have a good evening as well. Bye-bye.